Thank you. Thank you for the introduction to talk today. So I'm constantly amazed by what you guys can accomplish in a shift, but just remember, at least the residents don't have to do a direct carotid stick to get the angiogram anymore when people come to the emergency room. This is what they used to do back when our older attendings were residents, was cerebral angiogram on call overnight. So just keep that in perspective. We're just going to briefly touch on TPA. So all of you guys basically have grown up in the TPA era, so this is sort of part of your vocabulary and tool set already, but we're just going to briefly touch on the NIH TPA trial that was performed in 1995, which provides the basis of why we use TPA. This is one of a number of studies that looked at both alteplase and other types of TPA. So back in 1995, this trial was published in the New England Journal, and as you can see, what it indicated, so they basically looked at two different things in the study, and that was clinical improvement by the NIH Stroke Scale at 24 hours. And then in the second part of the study, they looked at clinical improvement in part 2 at 3 months. And the things to keep in mind is that they didn't see a significant benefit within 24 hours of TPA treatment, and that's often the case. We give patients TPA and we may not see a significant sudden improvement while they're in the emergency room. Sometimes we do when a vessel recanalizes, but oftentimes they stay about the same. So we expect the benefit to be appreciated more in the long-term follow-up. And if you wanted to sort of keep a percentage in your mind, there was approximately a 30% greater likelihood that the patient would have a good outcome of their stroke after receiving the IV TPA. You know, that's kind of how I phrase things to patients. And in terms of hemorrhage in the study, that was estimated to be about 6%. But if we look at more recent data, we think the risk of symptomatic hemorrhage is actually lower than this, and probably somewhere around 2 to 3% or so. This was sort of an artifact of how they calculated hemorrhage in the study, and they didn't really take into account whether the clinical deterioration was due to the hemorrhage or due to something else, like infection or hypoglycemia at that time, for example. So just bear in mind that we think in modern times probably the risk of hemorrhage is slightly lower than what was reported in this trial. So no significant difference in mortality seen with TPA in the 3-hour window. In terms of why we're now using TPA in the 3 to 4.5 hour window, this data was based on a trial published in 2008 in the New England Journal called the ECAS-3 study, which again showed a significant benefit to treatment of patients between 3 to 4.5 hours with IV TPA. And this trial, as I mentioned earlier, they looked at symptomatic hemorrhage after TPA in a different way. Really, in order to qualify as symptomatic hemorrhage, you had to have had your deterioration due to the hemorrhage and not to a different medical reason. And in this study, the risk of symptomatic intracranial hemorrhage was about 2.4%. And if they had used the NINDS definition, it would have been about 8%. So again, there is significant benefit in the 3 to 4.5 hour window, but when you actually compare it with sort of the magnitude of improvement in the 3-hour window, it's less. So this, supports the use of TPA, but also indicates that the sooner we use it, the better for the patients for likelihood of a good outcome. I like this graph, and some of you have seen this graph before on previous lectures. This was sort of a pooled analysis of several different TPA trials, and it kind of graphically illustrates the odds of a favorable outcome and how that drops off as we get further and further from last known well time at our time of treatment. So I like to keep in mind that for every 90-minute period that goes by after last known well time, the odds of a favorable outcome drop off by a factor of about 2. So this is sort of the impetus for time with brain and treating patients as efficiently as possible. So the acronym or message that we try to teach our triage nurses, who are usually the first ones receiving these patients, is the acronym BFAST. You guys have probably all heard about FAST before, but we like to add in the BFAST because it reminds them to think about brainstem signs and symptoms and vision symptoms. So things like vertigo, ataxia, impaired level of consciousness, can be things that are not really highly lateralizing, but can suggest a brainstem symptom. And we often, have to sort of actively ask the patient this. They may not complain of this to us initially. Things like diplopia can suggest a brainstem lesion or a visual field deficit. Again, oftentimes the patients don't complain of their visual field deficit. They may not even be aware of it if they're having a neglect syndrome. So we want to ask, but also make sure to check our visual fields. So FAST is facial palsy, arm weakness, speech, and that can be aphasia or dysarthria, and obviously our last known well time. So in both the Moses and Weiler emergency departments now, they're using a direct to CT protocol, which is a little bit different than what we were used to in the past. It kind of turns things on its ear because we're used to assessing the patient first, stabilizing them in the ED proper and then sending them off to CAT scan. But the way things should be working at both hospitals now is that either EMS pre-notifies us, and we love to get the FDNY pre-notifications to prepare for the patient, or they come in by EMS without a pre-notification, or they walk in, or someone drives them. The triage nurse and ED attending sort of assess initially to see if they think this is potentially a real stroke syndrome. The stroke page is activated. The patient gets a quick set of vitals, is brought to CAT scan, and during that time, the neurology resident will be coming downstairs and starting to ask the family or bystanders about the history, clarify your medication list, try to confirm the last known well time. So that information you should already kind of have established when the patient comes out of CAT scan. Of course, if the patient's unstable, they'll be going directly into the ED for stabilization first. And then hopefully by the time the CAT scan is completed, the patient comes out, they can do their exam, which is sort of a tailored exam with the NIH Stroke Scale, and then the TPA infusion can begin. We may actually in the near future be starting the TPA infusion in the CAT scan room while decisions are being made about whether or not to pursue the CTA and further imaging. So right now we're in the process of kind of in-servicing the residents about how to mix TPA, mix and prepare it, which I know is already done at Jacobi at the bedside. You guys are familiar with mixing it here, but we may in the near future be doing that at the other hospitals. For anyone that's not familiar with how to call a stroke code, it's on the clinical communications system on the intranet. So basically you would go to the stroke tab, and then you would type in here your hospital. If you don't have the patient name, that's okay. You won't have it when it's an FDNY pre-notification. If there was a pre-notification and you're just waiting for the patient to arrive, we'd like to get paged as soon as possible, and just click this button here. That's for us to help with data tracking purposes. It's helpful to let us know who the ED attending or resident is, so when we come down we can identify ourselves to them. And the resident will just come downstairs. We don't expect the resident to call first. Just tell us which ER it is, the resident will come downstairs as soon as possible. I know this system doesn't always work, and it's been a source of frustration for you guys. So if you're not getting an immediate response from us, and you can page us through 333 or 5731, that's okay too. We'll take it. However you need to get us down there, that's fine. Sometimes we get double pages, and that's okay too. So what is your job in a stroke code? So really the first and foremost question is, determining if this is actually a stroke syndrome. And I personally find that to be probably the hardest question of all, because people present with in all sorts of different ways. People don't often know how to describe their symptoms. These people are elderly, they may have baseline cognitive impairments, family may not be available. And then to determine if you think the patient's a TPA candidate. So again, try to get that number of 4.5 hours to stick in your head, because for the majority of people that will be their ideal TPA time window. And it's only a few people who meet certain exceptions that would fall within the 3-hour window. And then for patients that might not be a TPA candidate due to falling outside the time window or other contraindications we'll talk about, are they a thrombectomy candidate? At the same time, you're sort of multitasking, directing the nurses to get the 2 IVs in, getting the pump ready, getting people to and from imaging if necessary, speaking with the pharmacy. So you're really sort of multitasking and directing the team. So in terms of what the physician would be doing during this, so first and foremost, stabilizing the ABCs. And we looked recently in the Moses ER at patients who were called as stroke codes by EMS. And a large number of them were just canceled immediately by the AD attending when the patient arrived for other reasons, like clearly hypoglycemic or some sort of sepsis, something else like that. So really, sometimes we get a little carried away with the pre-notifications, but again, just stabilizing the ABCs first, getting that finger stick, making sure they're hemodynamically stable, a quick assessment to make sure there's not any like GI bleeding or something like that that's actually making them hypotensive, any obvious signs of trauma, things like that. Okay, obtaining the history, performing our exam, which we'll review, is trying to focus in on the NIH Stroke Scale, interpreting the CT. In certain scenarios and in certain hospitals, we'll be obtaining consent for TPA, ordering it, and then supervising the administration, because that's when we tend to have some errors, especially with nurses who are new and may not have used TPA before. And then doing the post-TPA monitoring. So what are our time treatment targets for door to MD? You guys are right there, so our door to MD is usually very quick. Door to CAT scan within 25 minutes, which we're meeting very easily now with the new direct to CT protocol. Our door to treatment time of 60 minutes. So this is a Heart Association benchmark that we need to constantly report back to them and also to the New York State Department of Health in order to maintain our stroke designation as Jacobi, Weiler, and Moses are 3 out of the 6 New York State Department of Health designated stroke centers in the Bronx. So our residents actually are treating about half the stroke patients, or probably more than half because of the large volume seen at these 3 hospitals in the Bronx. And this benchmark, we think in the near future, is going to be moved down to 45 minutes. So we just recently looked at our average door to needle time in our 2 hospitals, Moses and Weiler, and this year there's been significant improvements with the implementation of these protocols such as direct to CT, and it's hovering now below 60 minutes, which is a huge improvement and a huge accomplishment for both of the emergency departments of Moses and Weiler that we track the data on. Again, can't emphasize enough the ABCs. We often see people who are hypoglycemic. We've seen people that have actually fallen down the stairs and are becoming quadriplegic because they have a spinal cord contusion. So just make sure they're stabilized first, because the TPA is going to improve their likelihood of a good outcome, but it's not magic. And just doing the ABCs first is critical before even passing to that next step. Yes.
To that regard, is there a protocol that people can not go to CT first if they are felt to have an unstable airway, for example?
Yeah, exactly. So so it's a little easier, I think, at Weiler because patients are pretty much getting wheeled right by the desk where the residents and PAs and attendings are sitting to go to CAT scan. At Moses, what happens is the attending now is actually going out to the triage hallway and just doing a quick look at the patient, making sure they look hemodynamically and stable enough to go to CAT scan. Otherwise, they're going to come straight into the ER and be stabilized first. They're getting a quick set of vitals at that time. Okay. So obtaining the history, probably the most difficult step of the entire stroke code. And also getting the family to tell you it in a logical and concise way, very, very difficult. So you're going to be corroborating with family, home attendants, with a special focus on last known well time. A lot of times patients and family members tell you when the symptom was discovered. So the patient went to bed last night and then they found the patient in bed this morning. So it's really not the time that the symptom was discovered, but it was really when they were last known to be well. And then reviewing the TPA inclusion exclusion criteria. So if the patient can't tell you when they were last well, the last known well time would be established by when anyone else saw them at their normal neurological baseline. We've had people get treated because they were texting with someone and they developed dysdexia, and all of a sudden they just started writing a bunch of garbled aphasic words. What was the patient doing when the symptoms started? Were they watching a TV show that's at a certain time? One of my colleagues actually published that they treated someone because the husband remembered what inning of a Yankees game it was. So they went on to Twitter and looked up what was happening during that inning and what time that was, so they could time the onset of the stroke. more accurately? Was it a meal time, etc.? A couple of questions that were raised before the lecture. So if a patient awakens with deficits, again, the last known one was when they went to sleep. If the patient had a TIA earlier in the day and has returned to their normal neurological baseline, then the clock would be restarted, and the time of onset is when the new symptoms occurred. We see this sometimes with things like carotid stenosis, where maybe they have sort of stuttering deficits or like a large artery occlusion. So yes, we can restart the clock if they return to their normal baseline. Another question we're going to talk about more is what to do if someone has mild stroke symptoms initially when they present, but then they worsen. At what point do we decide that the risks and benefits of TPA are worthwhile treating them? So we'll talk a bit about that in a moment. So as you guys are probably aware, Activase, which is the trade name of Alteplase, which is the company that, so Activase is the drug that we use, has recently changed their packaging insert. The FDA recommended that they get rid of the exclusion criteria that weren't really evidence-based and just include in their packaging insert the ones that were felt to be evidence-based. So these are what we are now using at Montefiore, which basically mirrors the Activase packaging insert. On our intranet, under the stroke tab, we have our stroke protocol there, and this is part of the stroke protocol if you need to reference it. You can also just reference, like micromedics, what are the inclusion-exclusion criteria, it should be there for Activase. And those are significant head trauma or prior ischemic stroke in the previous 98 days. We don't know what would happen if we suddenly cause someone to reperfuse into a recently injured tissue. We think that may increase the risk of hemorrhagic conversion, so that's why we're not treating people who meet these criteria. Subarachnoid hemorrhage, presence of intracranial conditions that may increase the risk of bleeding, such as a highly vascularized tumor or metastases, for example, would give us certainly pause to treat someone. We often see patients that have meningiomas, which are really not usually well vascularized tumors, or people with small and ruptured aneurysms are very common, and that typically we would treat without any really hesitation. Recent intracranial intraspinal surgery, patients with uncontrolled blood pressure greater than 185 over 110. So oftentimes we do get patients with severe hypertension, and we can treat them, but we need to initiate labetalol or nicardipine to get them below this blood pressure parameter before we can start the infusion. Of course, any active internal bleeding, we would not want to treat them with TPA. GI, GU bleeding within the previous 21 days. Now, we sort of do this on a case-by-case basis, because if someone had a fairly mild GI or GU bleed and they're having a significant stroke syndrome, we would probably just discuss the risks and benefits with them or their family member and proceed based on the scenario. If they already have well-established infarction on the CAT scan when they come in, there's really not much point in treating them if we're just going to reproduce the dead tissue and put them at risk of hemorrhage. And unfortunately, this does occasionally occur that people come in with a great time window, but the tissue is already too infarcted, and then we would, not proceed. And then any sort of bleeding diathesis, such as low platelets, that may be somewhat, negotiable if it's just mildly low and the patient is having a severe stroke syndrome. And again, in general, platelets less than 100,000, elevated PGT, or someone actively on low molecular weight heparin, people with on Coumadin with an INR greater than 1.7, or people who are actively using the NOACs. It's not clear what the safety is of giving TPA in someone using a NOAC. Generally, we would consider treating them if it had been perhaps like 48 hours since their last dose, depending on the scenario, but if they're actively using it, we would not treat them here. We don't have a way in real time to check eccrine clotting time or factor 10A levels. And then some things that are sort of cautions, but are not actually, that are no longer exclusion criteria, are a recent major surgery within the previous 14 days, and MI within the past 90 days. So you guys probably recall back to an earlier time when MI in the last 90 days was actually an exclusion criteria, and when prior intracerebral hemorrhage was actually an exclusion criteria. That's no longer part of the Activase packaging exclusion criteria, which came as a surprise and concern to all of us. And again, I think what this just basically means is they've liberalized who you can treat, but you your clinical judgment is of course going to come into play, and with each individual patient, what the context of their prior ICH was may influence whether or not you're going to treat them now. So maybe someone with a lobar hemorrhage and amyloid angiopathy that had their hemorrhage 4 months ago would be very different than somebody that had a basal ganglia hemorrhage 10 years ago. So you would use your judgment on a case-by-case basis if you're going outside of these inclusion-exclusion criteria. You're probably familiar already with the fact that for people that we're treating within the 3 to 4.5 hour window, there are additional exclusion criteria. So again, TPA is only FDA approved within the 3 hour window. It's not FDA approved up to 4.5 hours, but is endorsed by the AHA, so we do use that to treat people. But there are additional exclusion criteria for those people that fall into that category. Age greater than 80, taking an oral anticoagulant regardless of INR. So again, if you're coming in within 3 hours and you're taking Coumadin, you can be treated if your INR is 1.7 or less, but if you're coming in beyond that time window, if you're on an oral anticoagulant, you would not be a candidate for TPA. Severe stroke scale, or history of diabetes and prior ischemic stroke. There are frequently times when we treat people who've had a prior ischemic stroke and diabetes in the 3 to 4.5 hour window, because we feel that their stroke does not represent just reactivation of the old deficits. Again, we would just document our decision making. If we can, we would, if it's possible to have some sort of a conversation with the family about, you know, the situation, we will, and then document that as well. When you're doing your assessment, you're going to obviously focus on the vital signs. You may need to start treating them to get them within their parameters of less than 185 over 110. You're going to do your general assessment, and then your NIH Stroke Scale. So for those who aren't familiar with the NIH Stroke Scale yet, this is basically an 11-item scale used to quantify the severity of stroke in clinical trials. So we don't use an NIH Stroke Scale number to decide whether to treat or not to treat. It is not part of the NIH, the AHA guidelines to say that you should or shouldn't treat someone based on a certain stroke scale. But we do need to document an NIH Stroke Scale at a time of initial assessment, which is usually done by the neurology resident in their note. Just to give you a sense of what the stroke scale includes: level of consciousness, orientation, command following, gaze, by checking their extraocular movements, visual fields, facial weakness, motor, ataxia, sensory, language, and this is assessed by the cards. Like you can see here, the picture, we call it the cookie theft picture. This gives you a great sense of how attentive people are to both sides of the page, what their fluency is, do they have good naming, just straight naming, and then reading of sentences and words, and then checking for extinction and inattention by doing double simultaneous stimulation. You can become NIH Stroke Scale certified, and I recommend that you do. You can go to the American Heart Association website, and they have like an education link. It's free. You take the course online, and then they provide you with a certificate. Probably wherever you go to work, they may ask you if you're NIH Stroke Scale certified. So I recommend doing that, you know, to be familiar with how to perform the stroke scale and do it accurately. And we see a lot of stroke mimics. Probably for every 10 stroke codes that we get called, we treat maybe 1 to 2 people. Some of the most frequent stroke mimics that we see are seizure, migraine, especially because we're a big headache center, so people, you know, have a whopper migraine, they come into the ER, and it can be difficult to figure out what's happening in that short freshman period of time. But oftentimes they can tell you that this fits a previous pattern of their migraines. This peripheral vestibulopahy, always difficult to figure out, is this peripheral vertigo, is this some kind of brainstem lesion? We try to look for other focal findings on exam to suggest brainstem dysfunction. Masses, subdural, subarachnoid hemorrhage, not typically confused with stroke syndrome, but can be hard because some patients do have a headache at the onset of their stroke. Hypoglycemia, just sepsis with reactivation of old deficits. So, you know, just kind of think through and be aware of the mimics.
Quick question.
Yes?
You said out of 10, there's about 1 or 2 that it might be a stroke mimic.
No, that we actually end up treating as TPA.
1 or 2 I'm sorry, so 10 strokes, 1 or 2 that you treat with TPA.
Right, so we got, I don't know what the data is for last year, for example, but for the year before, for 2014, we received about 900 stroke pages between Moses and Weiler, and we treated about roughly 90-ish people. So, it just kind of indicates that, the majority of time when we receive a stroke page, it may not be a TPA candidate. It may be something metabolic or seizure or headache. Usually it's something acutely neurological or an acute change for them, but we see a fair number of mimics as well, so it's important to kind of be aware and think through the other things in the differential. And
I thought you said that 1 or 2 of those patients were stroke mimics.
No, about 1 or 2 will be treating with TPA. Patients are presenting more and more frequently within the time windows now. Patients in the general public are aware. I think a lot of people come in actually asking for that drug that breaks up clots, so I think we're unfortunately going to be treating more and more people, but we do see a fair number of mimics as well. So how do we image these people? Non-contrast PET CT is, of course, the primary imaging modality. It can be helpful to rule out subarachnoid hemorrhage and intracerebral hemorrhage. We may see some subtle signs of infarct, like loss of the gray-white differentiation, or maybe a little bit of effacement of the cell size. There's a little early edema in one region of the brain. But most of the time, the CAT scan is going to be normal acutely if we really are getting a good story of last known well time. So on the left is an example of a dense vessel sign. This is a hyperdensity in the left MCA, indicating a thrombus. And then on the left here, we can see there's a good Sylvian fissure here on the right. And here we don't really see that because there's some edema, mass effect, loss of the gray-white. This might be the type of patient that we actually might not treat because their infarct is already so well established and visible on the CAT scan, but we might see more subtle signs of this when people present acutely. So after you've reviewed your CAT scan, you've done your neurological exam, spoken with the family about the inclusion-exclusion criteria, I'd like to do just a brief timeout to see is there anything we've missed in the history. Obtaining consent. So at Moses and Weiler, if you're treating patients within the 3-hour window, you do not need to obtain written consent. It is FDA approved. At Jacobi, I believe at this point still they do obtain written consent. I think that's an HHC regulation, or at least I know at Jacobi they do, as far as I'm aware, still now. In the 3 to 4.5 hour window, we do ask patients to give consent if possible. And we do explain to them, that this is AHA endorsed but not FDA approved, and generally most patients consent for it. We have a consent form that's a link on the stroke intranet page as well, so you can access it there. Usually the neurology resident will be doing that with their family. You're ordering the TPA, and I like to sometimes the coags are not back yet, and if the patient doesn't have a known bleeding issue, you do not have to wait for them to come back to treat the patient. But I usually kind of surveil periodically to see if they come back, because sometimes you do get surprised by patients that have hematological disorders and things, so just keep an eye out for those, but you can proceed to treat if the labs are not back yet. So what is TPA? So the trade name is Activase, and the generic name is Alteplase. There are other types of TPA that are used for other issues in the hospital, like streptokinase, so just be aware to make sure you're ordering Alteplase. And it's fairly easy to remember what you're dealing with because it's in a 1-to-1 solution, so it's 1 milligram per 1 cc. So if your patient should be getting 90 milligrams total of TPA, that would be a 9 milligram bolus and an 81 milligram bag to infuse. There should be 81 cc's of fluid in that bag. So it's basically a plasminogen activator. So it's basically breaking down the plasmin and dissolving these clots. And it actually has a fairly quick onset of action and a fairly short half-life. So much of the infusion is gone even just 10 minutes after the infusion ends. So, you know, we're surveilling these people, of course, during this event for things like GI bleed, et cetera. And I've had the experience a few times of patients actually having a GI bleed, probably 2 times in the past 6 years or so. What tends to happen is they bleed and then it stops. But again, it's hard to predict. But again, just kind of remember to yourself that much of it is out of their system soon after the infusion ends. But we think there could be some mild or lingering effects on the coagulation cascade, perhaps for the next day or so. So what is the dose for stroke? It's different than PE. Let's just keep that in mind. It's 0.9 mg per kg. And there is a maximum dose of TPA, so the maximum dose is 90 milligrams. So if you have a morbidly obese patient who's 130 kilograms, their maximum dose will be 90 milligrams. Okay? Different than PE, where I think sometimes things like 100 milligrams or maybe MI, sometimes 100 milligrams are used, so important to be aware of that. So the bottle that we use, which we're probably going to be hanging the bottles in the near future, contains 100 milligrams in it, so we'll always be wasting at least 10 milligrams and discarding that. Okay? 10% of the total dose is given as a bolus over 1 minute, and the remainder is given as an infusion over 1 hour. A caveat, because this has occurred a few times. So right now the pharmacy is sending us a TPA in a bag, and the bag says 100 cc's, because it's a 100 cc bag that they get that's empty, and then they squirt the TPA in. But they're only squirting in the amount that we're using, so it'll be like 65 milligrams in the bag. The rate should be set at 65 cc's per hour. We've had some confusion with people setting the rate at 100 cc's per hour, understandably so, because the bag looks like it has 100 cc's in it, but really the rate of the pump should be whatever the infusion dose of Activix is. Okay? So, when we're starting the TPA, we make sure the patient's on a monitor. Do they have 2 IVs in case we need to give them labetalol or nicardipine for the other IV? Making sure we've got the right drug and the right dose. Are they below a treatment parameter of 185 over 110? We're going to document the time of the bolus and then make sure that the pump is programmed correctly, because that's sort of a critical time period when errors can occur. And then we usually kind of briefly speak with the nurse about our neuro and vitals check protocol. So just to touch briefly on what to do if you do have to get that patient to the right blood pressure parameters before you start the infusion. This is from the AHA. Typically we would start with 1 or 2 doses of labetalol, and if it doesn't look like that's really working for the patient and holding them at the right blood pressure, then we can proceed to a nicardipine drip. I've really never had to proceed further than 1 or 2 of these treatments, which usually works fairly effectively. So how do we monitor the patient during the infusion? Basically, so for the first 2 hours, which is during the infusion and the hour afterwards, we're going to be doing neuro and vitals checks every 15 minutes. And once we start the infusion, we need to maintain metabolic blood pressure less than 180 over 105. So just have that number in your mind for follow-up. Looking at reasons why people bleed after TPA, and probably the biggest reason people bleed after TPA is when they have a very large infarction, and possibly the infarction's a little bit advanced by the time they arrive, and then you're kind of reperfusing a large area of dead tissue. But other protocol violations, like the blood pressure not being controlled and being allowed to be severely hypertensive, can also be a risk for bleeding.
So typically we don't drop the blood pressure on more than 25% of the time because the severely high blood pressure is something like 240, 250. Are you going to drop them to 180, or you're just going to say lower than 25% and say they're still too high, not a deviation?
Yeah, it's a good question. It does occasionally happen. I really think in order to treat them, I think you should adhere to what the blood pressure parameters are per the AHA, because I think it would be hard to know what would happen safety-wise to them if you didn't, or medically legally, honestly. So I think if you think they're a good TPA candidate, they're having an acute neurological syndrome, we would actually proceed this way. But the understanding that perhaps there are rare patients where dropping their blood pressure could precipitate more issues, but if they're if they're having that problem because they're having a large artery occlusion, then in the long run, getting the occlusion open as however you can acutely is probably worth it. Yeah, that's a good question. That does come up occasionally. Okay, great. So during the infusion, inevitably the daughter shows up with a sandwich, and the person, come back, patient's like happy they've got their TPA and they're like chatting, or eating their sandwich, their arm is bent, and you realize the pump's been beeping for 20 minutes, and like half the TPA hasn't gone in yet. So just periodically check back to make sure the TPA is infusing properly, that their blood pressure is being monitored, the neuroexam is being monitored. If they suffer neurological deterioration during or at any time in the first 24 hours after the infusion, we're going to stop the infusion and bring them to stat head CT. So if they're suddenly acutely vomiting, they have a sudden severe new headache, or they are deteriorating, those three reasons that would concern us that they may be bleeding, we would stop the drip, get a head CT. If it's negative, we can resume the infusion. Some people are vomiting anyway if they have a posterior circulation stroke, but we do need to be cautious and aware of this and monitor them carefully. Okay, and again, we talked about the blood pressure parameters, and again, even after they receive their TPA, we oftentimes continue to use labetalol as needed in recording. If we're really struggling and we cannot get them under the treatment parameters, then we may end up not being able to proceed to give them TPA, but generally we can get that controlled. Okay, so important to be aware as well of angioedema or anaphylaxis, not very common. I've seen it happen probably about 3 times or so in 6 or 7 years, but it does happen. I've seen both angioedema of the lips and tongue, as well as like diffuse urticaria or urticaria wherever the patient's touched during the infusion. So something to be aware of, and usually this responds well to steroids and Benadryl. And then we talked already about hemorrhage. Certainly we're going to stop the infusion, check the stat head CT. Unfortunately, there's not really any great evidence-based treatments for bleeding after TPA. What we would do is give people cryoprecipitate. We think that rebleeding their fibrinogen is probably important based on the mechanism of action of TPA. And we would give them platelets. It's not clear whether or not this is what this is adding exactly, but in patients who frequently are on antiplatelets when they come in, certainly we would want to do this. Continue to follow up, and if necessary, we may need to consider neurosurgery consults, but it's like they need a hemicraniectomy. And we have had patients who have bled and who have gone on to get a hemicraniectomy and who have had some degree of, decent neurological outcome. Obviously, neurosurgery is not anxious to operate on someone that just got TPA an hour ago, but sometimes they may continue to follow, and if the patient's not improving, operate on them sometime later that day, or etc. Someone asked a question to me before the lecture about patients who have mild neurological deficits and what we do in that scenario. And there's been a lot of interest in the literature on this topic, looking at patients with minor deficits and what happens to them after they're admitted and what's their outcomes. And it looks like for those patients, about 1/3 of them will stay the same during their hospitalization, about 1/3 will get worse and end up needing to go to perhaps maybe some sort of rehab facility, which is not our goal, right? Our goal is to get these people home and functional again, and about 1/3 will improve. So there is no lower limit to the NIH Stroke Scale at which we would treat people. We don't have a lower limit on our inclusion-exclusion criteria. That's not part of the AHA guidelines or part of the Activate guidelines. And I recommend wherever you guys go to practice, look at the TPA inclusion-exclusion criteria. You'll see a lot of silly things out there that may have been in the protocol for years. And in fact, medically, if you withhold TPA from someone that has a measurable, potentially disabling neurological deficit and they don't improve, that may, I think, put you at more risk than going ahead and treating them per the guidelines. We have people with an NIH Stroke Scale of 4 that may be aphasic or significantly hemiplegic or in their dominant hand. We feel like if it's a deficit that could impair the person's level of functioning, such as their ability to work, their ability to ambulate, their ability to live, fully independently, then that is a deficit worthwhile treating. When the residents call me and they're like, I'm not sure, it's kind of mild, but I ask them is, if you had this deficit, would you want to be treated? So if it's like one finger drifts, that's probably not something that's going to impair anyone's life, but even just weakness of a dominant hand alone could significantly impair someone's ability to work. So I would look at the deficit in that context when deciding whether to treat patients. Okay. Sometimes people come in exceptionally mild, and after a conversation we decide maybe we shouldn't treat them, and then they worsen during the TPA time window, and then we would treat them. And if it's sort of a smooth, mild deterioration of their initial symptoms, I think you can just go ahead and treat. If there's suddenly a major change and major deterioration, it's probably wise to get another head CT before treating them if there's a concern that there may have been some spontaneous bleeding. But again, we've treated people with NIH Stroke Scales of 0 actually, because you don't actually get a point for hand weakness, and hand weakness can be disabling. So I think people in general are moving towards kind of rethinking this idea of too good to treat. Okay. So what do we do in patients who are beyond the 3-hour window, or people who have a large artery occlusion? What is our option? So we have mechanical thrombectomy. Based on kind of a smorgasbord of the recent thrombectomy trials, we're considering people up to about 12 hours from last known well time. We will consider wake-up strokes if the person looks like they have what we call a good tissue window. So this means that although their last known well time was 6 or 8 hours ago, the non-contrast head CT does not show a well-demarcated large territory of infarction. So we think that they're ischemic, but perhaps not infarcted yet. So we will consider wake-up strokes, if they come within, let's say, 12-ish hours or so from last known well time. So I think our general message to your triage nurses is certainly call us for any stroke code within 6 hours of last known well time. But if the person looks like they have a major neurological deficit, if they are hemiplegic or hemiparetic, severely, if they're aphasic or have a gaze preference or a severe neglect syndrome, just page us. We'd rather, we're happy to get the page. We're going to be doing the consult anyway, so just go ahead and page it as a stroke code so we can assess them for whether or not they'd be a candidate for thrombectomy. Again, things to kind of focus in on to make us think of a large vessel stroke are aphasia, hemiplegia, gaze palsy, neglect, and then of course our posterior circulation patients, which again can be hard to sort out, but things like vertigo along with diplopia, or signs and symptoms of bilateral brainstem involvement like bilateral weakness or ataxia, impaired level of consciousness due to top of brainstem involvement, just go ahead and page us, because we'll even consider doing basilar artery thrombosis treatments, more than 12 hours later, to 24 plus hours depending on what the patient's symptoms are. So typically the device that's being used nowadays is the Solitaire device. This is called a stent retriever or stent retriever. And basically what happens is this is put up into the artery and then it's sort of collapsed. Well, it's sort of expanded, and what happens is it kind of is then collapsed and sort of smushes the clot inside of itself and captures the clot. And then the entire thing is taken out, and we often see like a clot, usually about 1 to 2 millimeters in diameter, which is about the size of an intracranial vessel. We know the clots come out, so that's basically capturing and removing the clot. So there was a number of trials published, like Mr. Clean, Escape, Swift Prime, etc., looking at thrombectomy in different ways over the last year. The one that we cite most frequently is the Escape trial. That's because Montefiore actually was a site for this, but we never got to enroll a patient because the study was stopped early for efficacy. But everyone here was kind of primed to go with this trial according to the protocol. The protocol is a very easy to use protocol. doesn't involve things like CT perfusion that you need special radiologists to fiddle around on the computer with for a long time afterwards. It's just basically CTA performed here, non-contrast head CT. So I think a child to be familiar with to help with the decision making is the ESCAPE trial. So this trial basically looked at mechanical thrombectomy and best medical care versus medical care alone. It was a randomized prospective trial. And it enrolled adults within 12 hours of last known well time. And the way they chose people to be enrolled in the trial was based on their non-contrast head CT, and we're going to talk a little bit about that because you guys will be seeing us doing this protocol, and you'll be participating in this, getting patients kind of along this algorithm, as well as the multi-phase CT. So this is a little different than the usual just plain CTA head that we do for other things like aneurysms, etc. Patients were treated with IVTPA if they were an IVTPA candidate, so we don't withhold IVTPA for patients that are going to go for thrombectomy. There does not appear to be any significantly increased bleeding risk with giving people IVTPA before thrombectomy. We kind of anecdotally feel like maybe it actually helps a little bit because sometimes during these procedures pieces of clot kind of embolize distally, and we think maybe it helps, but again, I think bear in mind that treating them with IVTPA beforehand is actually beneficial for other reasons that we'll talk about in the next slide and does not expose them to increased risk of hemorrhage. Yes, you had a question?
Oh, no, it's just
Oh, okay, thank you. And the voluntary perfusion time in this study was 90 minutes. So that means 90 minutes from the patient arriving in the ER, getting their IVTPA, et cetera, to actually being on the angiogram table and the clot coming out. So this is a pretty short time window. We don't usually meet this 90-minute period now, but we're getting closer and closer to it. So I think, we're in real life trying to recreate this trial. Primary outcome is modified ranking scale, which is the scale of disability. So what is the aspect score? This is a score looking at non-contrast head CT and dividing the brain up into different segments. So the segments, there's 10 segments that are looked at. The insular cortex, the lentiform nucleus, the caudate, the internal capsule, and then our cortex. And that's and we look at two different levels. At the level of the basal ganglia, which is of course where we're seeing those basal ganglia structures, and then at the supraganglionic level. And basically, for each part of the brain that has infarct established on it already, on the non-contrast head CT, a point would be deducted from the total score, which is 10. So a normal brain would have an aspect score of 10. And then let's say the patient had a left MCA infarct and the cortex of their insula was starting to kind of have some gray-white loss, and then maybe their anterior temporal lobe. That would be an aspect score of 8. We've deducted 2 points, but maybe the rest of the brain looks normal. So we would consider that a very favorable candidate for thrombectomy because what we want to be working with here is a brain that doesn't have a lot of infarct yet. So we can reopen the vessel and we perfuse ischemic but not yet infarcted brain. So the higher the aspect score, the better for thrombectomy. And they enrolled people with aspect scores of 6 or higher as part of this study. And then what is the ESCAPE protocol that we do? This is a multi-phase CT, so initially a CTA is done, but then in a very rapid sequestration of just a couple of seconds, 2 more passes are made through the head. And so basically we're getting a dynamic sense of how the blood is flowing through the collateral circulation. It's kind of like a really poor man's angiogram in a way, because angiogram is a dynamic study. So this is demonstrating good collateral. So here's an MCA occlusion right here. But on phase 1, we actually see that the more distal vessels look pretty symmetric. So we know that blood is very rapidly coming along through collaterals of the posterior cerebral artery and the anterior cerebral artery to flow retrograde down to the MCA territory. So this person has good collaterals that have been keeping the ischemic tissue alive enough that they don't have a lot of infarct yet on their scan. We can see maybe the dye is lingering around a little bit longer on this side, implying that there is, sort of some slowness of the retrograde filling, but then it starts to wash out more or less kind of symmetrically with the other side. Here's somebody with intermediate collateral, so we don't see the collaterals filling in very well here, certainly not as symmetric as the other side. Dye's kind of lingering around for a while. And then here's someone with poor collaterals. We actually really don't see ever, very well filling of the collaterals here. So these types of patients are usually the ones that we are seeing infarct already established or establishing quickly when they get to the ER. They don't have good collateral circulation at baseline, and for these patients, they are less likely to kind of tolerate the time it takes to get the clot out. They'll just kind of end up reperfusing dead tissue by the time they finish their procedure. So what we're looking for is somebody without a lot of infarct and with fairly good collaterals, kind of keeping the brain alive long enough for them to get through the procedure. Does that make sense? So when people come in and say, we're going to do CT escape protocol, the CT in the ER at Moses and Weiler is protocol to do this study, and the techs know how to do this study, so that's what we want to be ordering for the acute stroke patients. Trials showed a significant benefit both in terms of good neurological outcome as well as actually some benefit in mortality. So this is really proving not only can the vessels be reopened, but the quicker the vessels are reopened, the better the likelihood of a good outcome. And basically, this applied to all people of all ages, all different stroke, vessels, so basically ICA, MCA, and even in the patients who didn't end up getting thrombectomy, who just got TPA and then got randomized to placebo, the people that got TPA did better than the people that didn't in terms of their vessels reopening. So just giving them the IV TPA itself, that kind of in a way sort of proves that theory as well, that it's beneficial for reopening the vessels. I'm going to kind of quickly conclude because I know we're coming to the end of our time. But what do we do on the on our side when we admit the patient? So we continue the neuro and BP checks post-TPA. We usually monitor people on telemetry, assess their cardiac risk factors, including what does their echo look like. We can't give these patients any type of antithrombotics in the first 24 hours post-TPA, so no aspirin, no Plavix, no AC within 24 hours of receiving TPA. And all patients should be NPO until they've received either the 3-ounce water swallow test, which is usually done at this time by the neurology residents, or they've been seen by speech pathology. So NPO until they've been formally assessed for any meds or food. That's basically it. I think wherever you go, just bear in mind that all of this is outlined very well in the American Heart Association guidelines, which are available for free online. You don't need a password or anything like that. So if you find yourself coming up with questions while you're treating patients, this is the place to go, the American Stroke Association website, under professional, and then under guidelines. The most current guidelines are from 2013. And any questions? Yes?
You may not know the answer to this, but for patients who've been started on TPA and need to be transferred for a thrombectomy, say from Weiler to Moses, are there EMS guidelines that say they have to be, a physician has to go with them?
No, a physician doesn't have to go with them. They don't have to go with them. They should be able to transfer our TPA to their pump. I know there's been periodically some issues with that. Sometimes we've actually just handed them the pump. Sometimes they've said we don't know how to operate the pump, and one of us has actually gotten into the ambulance with them. That has happened. But no, they should be aware of what our upper limits of blood pressure are and have some mechanism of treating the patient for blood pressure if they exceed that. But most of the time they can transfer patients quickly enough that they fall within those that 15-minute interval while they're en route. But they should be able to transport people as ACLS without a physician.
Sure.
Just to comment on that, Lauren, as a physician, you offer nothing to a patient in the back of an ambulance that a paramedic can't. It's all restricted by what toys you have in the back of the bus. Right? So there's really no point for you to get in the back of the ambulance.
One question.
Yes.
I feel like this debate happened a lot in maybe 2012, 2013. Debate whether TPA is actually beneficial or not. There's a lot of criticism maybe on the NIMS trial and EP CAS 3 trials as well. And I guess ACEP adopted this in 2013, so we have 3 years to accept this now. And so it's become somewhat standard. I think you're suggesting that if we didn't treat a patient with deficit and they didn't prove that he might be medically legally liable, so. But you also give the example that if someone had abdominal deficit of some sort, and let's say you do treat them, and they end up with deficit in ICH, am I medically legally protected in that case?
Yeah, it's a good question. I mean, so again, from the aspect of saying what is their NIH Stroke Scale, I'm not aware of, by the AHA, any number cut off. So I don't think I don't think they could say that you treated somebody with a stroke scale of 1 and they had an adverse event, so you did something medically appropriate. I don't think that would be the case. What the AHA says is measurable neurological deficit. So that you would interpret that as there's a deficit. I think they say measurable disabling neurological deficit. So I think that would be in your clinical opinion of what you think the deficit is at the time. I would hope that if you treated them according to the appropriate protocols and you documented your decision making, I suppose people could sue for anything really, but I think you should, if it fell within the standard of care, then I think you should be in the right. I don't know if other people want to add a comment to that. That's a good question. That reminds me to say one other thing. We don't get informed consent, as I said, for the 0 to 3 hour window, but we do document in the chart assent, if verbal assent was given. So I document something along the lines of, I discussed the risks and benefits of TPA with, Mr. So-and-so's wife, and, including, risk of, bleeding, significant neurological impairment, death, something along those lines. And then I say, and verbal assent was obtained. Because I do think it is important to at least explain to the patient, if possible, what you're about to treat them with. So we do generally document that a conversation occurred and that assent was obtained. And the way the AHA actually addresses this issue in their guidelines is that whenever possible, a conversation should occur. But documentation of consent after an explanation of the risks and benefits written by the physician is acceptable. Meaning that you should, whenever possible, document that some form of conversation occurred. If you're unable to have that conversation because no one's available, then you can proceed to treat them. But I think you just have to use your unfortunately with medicine, we have to use our clinician brain and our medical brain too. So you document, I think this person had a potentially disabling neurological deficit. You proceeded to treat them within the established guidelines. Family, was informed of the potential risk benefits of TPA and gave their verbal assent. That's, I think, the best we can do, honestly.
When they review the cases, there were many more cases of successful suits against doctors who was not given and giving, so you're more at risk for not giving when you look at these cases.
Yeah.
I think one of the concerns, especially people who come in where the baseline is a left hemiparesis, maybe a 3 or 4 out of 5, and they drop down to a 2.
Yeah.
It's hard to apply the stroke scale, and when would we consider saying that's just a recrudescence of an old syndrome versus acutely hitting someone like that. The risk factor being they had a stroke in that area once before is a risk factor for the second one. How we handle those in consideration for people like TPA.
Yeah, it's always very hard to tell when someone has a poor baseline initially whether or not they've had a new stroke syndrome. I think you just have to do it on a case-by-case basis, to be honest with you. If it seems like a major deterioration that now would be disabling for them. Sometimes we receive patients who are bedbound from a nursing home and minimally verbal at baseline, and there may be a very slight fluctuation in their exam that might make me treat a young person, but in that patient, it may not necessarily be disabling to them, and sometimes it's hard to tell if a new stroke syndrome is even occurred at all. Then I would probably take a case by case and just document what the thought process was at the time. Those cases are very hard to sort out. sometimes the people's baseline NIH Stroke Scale is not 0 because they have a pre-existing left hemiparesis, so their baseline stroke scale will be like 4 or something like that. So that's why it's worthwhile also writing in free text like, patient not appropriate for TPA because they're at their neurological baseline. So you don't want to just rely on saying, well, I documented a 0 NIH Stroke Scale, so that explains why I'm not treating them, because not everyone's NIH Stroke Scale is 0 at baseline. If they're demented, it won't be 0 because they don't know what month it is. So just document, if you're not going to treat them, you're not treating them because they're at their neurological baseline. And that should, I think that should make it abundantly clear. And we sort of get, we get humbled either way, because sometimes people look fine in the ER and the next day on rounds they're hemiparetic, but we have to make this, and a lot of times families like, I don't know, can I think about the TPA? And I just explain to them, we don't know what's going to happen tomorrow, we have to make the decision based on how you look now. And I think just bear that in mind, and what happens the next day is a different situation, but you're making the decision based on how they look at that point in time. If you, in good faith, don't think they have a neurological deficit, you don't think this is a significant deficit, you document that, as does occasionally happen to us, and the patient is weaker the next day. It's unfortunate, but you would be judged based on your decision making at the time, that you documented things.